Granulosa theca cell tumor presenting with postmenopausal bleeding. The patient was a multipara who was unsure of her age, but she was 10 years postmenopausal. She presented with a history of postmenopausal bleeding, and the clinical and ultrasound diagnosis were suspected endometrial cancer. At the time of the ultrasound scan, the patient was not bleeding. But 2 days after, she was rushed to a gynae emergency with profuse vaginal bleeding, for which she was transfused. This is the video of the patient, not the bulky uterus or age, and the normal position of the uterus. In postmenopausal women, uterus is often seen to be axial in position. So, not the homogeneous myometrium, clot within the endometrial cavity, not clot around the isthmus and in the endocervical canal, not that what appears as irregular endometrium here is due to the blood clot, not that the endometrium is irregular. That's demonstrating whether the clot within will jiggle. Same patient. So not the endometrium here appeared in Theca and somewhere here. This is actually the endometrium. Here you have blood clot adhered to the endometrium. So the endometrium is thin, and therefore endometrial carcinoma is less likely in these patients. Again, not the normal vascularity, the arcuate vessels, the radial, and just one spiral artery in here. So the endometrium is not highly vascularized as is expected in patients with endometrial cancer. Not the blood clot around the isthmus, and this area, this irregular area is not irregular endometrium, was blood clot attached to the endometrium. Here are the still images, not the endometrium here. It's thin. This appearance is of blood clot, not endometrial thickness, and not the vascularity, suggesting more benign than malignant lesion. Shared surgery, and not this uterus, bigger than a woman who is 10 years postmenopausal, but not the slit-like endometrium. This solid ovarian lesion was missed on ultrasound scan, and this was the cause of the postmenopausal bleeding. So, what was the histopathological diagnosis? Granulosa theca cell tumor, and the endometrium showed senile cystic atrophy. The endometrium is not measured on transversation, but in this video, I want to demonstrate how thin the endometrium is on transversation and compare with the surgical specimen. This is sagittal section, not the thin endometrium here, still demonstrating jiggling of blood clot within the endometrium. Here is a blood clot adhered to the endometrium, giving a false appearance of irregular endometrium here. not the blood clot here also, around the isthmus, and the endocervical canal. So now in transverse section, look at it. Look at how thin the endometrium is. Slit-like endometrium. So what are our learning points? Extremely important to do a systematic examination. If that was done in this patient, the solid ovarian lesion wouldn't have been missed. When a uterus of this size is seen in a woman who is 10 years postmenopausal and there are no features suggestive of endometrial carcinoma or hyperplasia, it's extremely important to rule out estrogen-producing tumors. Reviewing the image after the histopathology body is also important to help in the learning process. If I had not followed up this patient, I would have known that the cause of the postmenopausal bleeding in this patient was granulosa, Theca, cell tumor. So follow-up is extremely important for learning. Thank you very much.